My name is April. Some of you know me. I'm a project manager at the division. So for those of you that I haven't had the pleasure of meeting yet, hello and a big warm welcome. You are here tonight, and I'm so happy to have you guys. You're here tonight as the third in our three-part series on medication management, which is part of our AMHSU Shared Care Project. The session that you guys are joining in on tonight is depression and insomnia, medication management of depression and insomnia. And we're very pleased to be joined this evening by Dr. Varinder Parmar, who is a psychiatrist and sleep specialist at Surrey Memorial Hospital. Some of you may have had the pleasure of meeting him already. Just a few small housekeeping items before I hand our evening over to Dr. Parmar. If you are comfortable having your camera on, we'd love to see your faces. Please feel free to turn it on. I do know that Zoom fatigue is a real thing, so don't feel pressured to have your camera on if you don't want to. Please use the chat function to say hello to some of your colleagues who were joining us this evening. You can also use the chat function to ask questions as the presentation goes along. I'll be monitoring the chat, so Dr. Parmar, with your permission, I will interrupt you periodically if there are questions. We'll also use the raise hand option, so for those of you who are on your computers or know how to toggle to the right on your mobile device, you have the option to raise your hand if you'd like to ask a question during the presentation, so feel free to do that. And at the very end of the presentation, as always, we have an evaluation that will get you guys to fill out. It's just a quick one. I'll put a link to the evaluation form into the chat box at the end of the session, and that's what will help get you guys your CME certificate, is completing that, the evaluation at the end. And so with that, I will hand over our evening and the conversation to Dr. Varinder Parmar. Thank you so much for being here tonight.
Thank you, April. So I think majority of the audience are family doctors. So the way I think we are going to do presentation is after 1 hour. I think if you're comfortable in managing insomnia with medications, whether it's initial insomnia, maintenance insomnia, whether it's terminal insomnia, that is more than enough what we are expecting. So when we talk about sleep, there are few areas from mental health point of view that we want primary care physicians to manage. ADHD is one of them. Insomnia is another one. And we see a lot of time, it's challenging for family doctors to prescribe medications if it's needed, of course, because of course, addiction potential of medications. But there are so many other medications which we are going to talk about today that you can use if you are comfortable with it, if you have some, if you can, of course, learn more about it for insomnia, and then it prevents the hassle of patient being referred and wait as patient is struggling with insomnia. So the way I divided the presentation is, first we are going to talk about normal sleep. What is it? What is sleep basically, and why do we sleep? And when someone sleeps, what happens to us? So that will be 15 to 20 minutes. Then second thing we are going to talk about is, how do we measure sleep? Like once you are asleep, for example, okay, how would I say that patient A sleeps well and patient B does not sleep well? Apart from subjective symptoms, how do we justify that sleep quality or quantity is bad? So that means measurement of sleep. So 15 minutes we are going to spend of talking about normal sleep. 15 minutes we are going to talk about how to measure sleep. And then 10 to 15 minutes we're going to spend about talking about different sleep disorders briefly. And in the end, last 15 minutes, we're going to spend about talking medications, use hypnotic medications, what all medications are there in the market, Canadian market at this time, and what all things we can prescribe depending upon the symptomatology. So anytime, please feel free to interrupt me and make it interactive. So these are the 4 areas of sleep. So I'm a psychiatrist. I work at Surrey Memorial Hospital. I run a sleep clinic which is located in front of Surrey Memorial Hospital, and that's the only sleep clinic we have in this area, in Surrey Delta area. So Sorry. Okay, so what is normal sleep? When someone asks, a patient or anyone asks you, hey, how many hours should I sleep? So most of us probably say 7 or 8 hours, but that's not the answer you should give. There are a lot of individuals out there who sleep 4 hours and function very well. I think Donald Trump is one of them. That's what they say in media. So that's not the answer you're going to say 7 or 8 hours. What you're going to say is whatever makes you feel refreshed in the morning that's more than enough. And that could be in 4 hours, that you can achieve in 6 hours, or that you can achieve in 9 hours. But the moral of the story is that in the morning, when you get up, you feel really refreshed that, oh my God, I really had a good night's sleep. If the audience themselves don't have that feeling that I really had a good night's sleep, there is some problem with your sleep, because majority of the population in the world feel that way. So a sleep duration is usually 7 or 8 minutes is considered for human beings. 7 or 8 minutes on an average is considered fully resorptive for most adults, right? Now, sleep onset, like when you go to bed, how much time it takes for you to fall asleep varies with individuals. That's where the family doctors are going to have big problem, because a lot of people say that when I go to bed, it's difficult for you to fall asleep, called initial insomnia. And that is where the problem is. That's where we are going to have argument pay with the patient, hey, sleep hygiene, this, that, and patients are going to say, I tried everything. But the answer to the question is 15 to 30 minutes when you go to bed. If your brain is conditioned to bed and sleep and brain, it should take about 15 to 30 minutes, right? So in general, as we get older, the quantity as well as quality of sleep decreases. But overall, if someone asks you, how much do I need to sleep in order to feel better, there is no answer. It's as good as, hey, how much should be your height to make you feel better, make you good looking? But that there's no answer to the question. But on an average, if a man is 5'8" or 5'9", we can say that. But there is no answer to that question, and that's exactly what the sleep duration is. Now, why do we sleep? Like all of us sleep. All of us means all birds, all mammals, everyone sleep. All animals sleep. Okay. So if you see this chart, if you're focused, you can see that killer whales sleep 2 hours, horses sleep approximately 3 hours, humans sleep about 8 hours. Whereas you go to all the rats, chipmunks, pythons, ducks, so all they sleep several hours a day. This is normal for them. So when we sleep, our brain rests. Both the hemisphere sleep. Some birds, some mammals, with evolution, because they are being eaten by other mammals, they have unihemispheric sleep. That is, one side of the brain sleep, one side of the brain awake. But each and individual animal or mammal sleep differently, and they have different on an average hours, and human beings are 8. Why do we sleep? If I ask someone a question, the important answer to your question is the purpose of sleep is it's helpful with the memory. Brain has to sleep. It's like resetting your computer. You have to reset your computer to make it, you get it faster. If you keep working, it's gonna, and then you don't sleep well for months, years, it's gonna start freezing. And same is your concentration, your mood, you will be more irritable, productivity, everything is gonna go down. And longevity, this is a research, longevity is gonna go down also if you don't sleep well, for obvious reasons. So sleep is not that you're unconscious, it's just loss of wakefulness. And this is because it's important for learning. And this is very important point, because a lot of times we see university students, they're not doing, like in the end of, before their some exams or something, they spend significant amount of time studying and not sleeping well, and it's not going to be registered in the brain. So it's very important for them to sleep good number of hours before they go to bed, before exams, because that's important for learning as well. So now when we talk about sleep, I think majority of us probably know this. This is the most important slide in first part of normal sleep. When we talk about sleep, we divide sleep into two broad categories. And one we call it non-REM sleep, and one we call it REM sleep. So what it means is REM and non-REM, what it means is REM is called dreaming sleep, whereas non-REM is called non-dreaming sleep. So non-REM is divided into three stages, N1, N2, and N3. So what it means is when you go to bed, you don't start dreaming immediately. If someone starts dreaming immediately, there is something wrong with them and they need to see a doctor. If you have a good night's sleep, if you take a nap, if any one of audience take nap during daytime and they start dreaming, they should not dream during taking nap during daytime. There are only two differentials that comes if they start dreaming. Either they did not sleep previous night well, which means they are, which is called sleep deprivation, or they have narcolepsy. There is no other explanation. So REM sleep should not come during daytime when you're taking nap. If this comes, there is a reason that previous night or last few nights you did not sleep well at night. So when you go to bed, let's say typically you go to bed around 10 o'clock. If you end up falling asleep in 15-20 minutes, first stage that's going to come is non-REM sleep. And as we're going to get through the night, in the morning, you will have more REM sleep. And that's why majority of us wake up dreaming. We don't wake up when we're not dreaming. We usually wake up in REM sleep. But just in case, if someone comes in the middle of night, you're sleeping, and someone wakes you up in non-REM sleep, you wake up confused. You don't know what's going on. And then it takes few minutes or few seconds for you to come to in terms what's going on. Now, these things are very important because any pathology in these stages leads to sleep disorders. Now, when we talk about in general, non-REM sleep, we have what we call deep sleep. Deep sleep is called N3, which is 5%. REM sleep is called dreaming sleep, where our brain is active. And that's called, when we are dreaming, is called REM sleep. It's 25% of the sleep. Now, why do we have REM sleep? Now, if you sleep these slides, as we are awake, let's say if you do EEG and put all sorts of leads on my brain right now, I'm talking, I'm active, I will have what we call beta waves. It will be very fast. Now, this is very important for me to let you guys know, because we're going to come after in the other slides how we can manage the medications and everything, how they are affecting this. So the beta waves are faster waves. If you see 15 to 30 hertz of sleep, of hertz, these are very fast wave. So they are called beta waves. Now, as I'm slowing down and I'm entering into stage 1, which is N1, and it is called theta waves, which is slowed down 4 to 8 hertz. So first when I'm drowsy, it's becoming what we call alpha waves, right? And then, so beta waves, right now, I'm falling asleep in 15 to 30 minutes. Alpha wave, which is slowing down. Theta waves means stage 1, slow down further. And then it's slowed down further in stage 2 and 2. But then we get into deep sleep, which is nobody can wake you up in that sleep. If someone wakes you up, you get up in the middle of night, confused, and we call it confusional arousals. Nobody gets up. It's a deep, you see, it's called delta sleep, and look at the frequency, 0.1 to 4 hertz. Now, if that's the case, then probably lions are going to eat us, probably tigers are going to eat us. Then through evolution, how did we survive and became human beings? This is because sleep goes in cycles. So let's assume 10 o'clock or 11 o'clock, I went to bed, 11 o'clock I go to bed, and I'm 15-20 minutes, I reached stage 1. stage 2, and by 12 o'clock, let's say midnight, I'm in my deep sleep. And I should stay in deep sleep, ideally, to feel refreshed, but that's not the case. Then 1 o'clock, if someone comes, they can do whatever they want to do to me. And I won't even know that. But how did we, even the evolution survived? Because then we came REM sleep. And REM sleep, our body, our brain becomes faster. We know now what's happening. So in REM sleep, our brain is working and our body is paralyzed. In dreaming sleep, in the non-REM sleep, our brain is paralyzed and our body is working. So you're tossing and turning, tossing and turning. But in dreaming sleep, you're paralyzed. And that's very important. And that's why in REM sleep, you see the waves, it becomes sawtooth, it becomes faster. So if we remember this basic of sleep medicine, then it will help us to choose the medication to treat insomnia, and what happens in mental illness, it will help us a lot. So what I'm telling you in nutshell, what it is, if you see this is called hypnogram. Now, if I see a patient for sleep disorder, for instance, this is the normal thing that you will see in the consults as well. So if you see 10 o'clock, if you see the x-axis and y-axis, 10 o'clock is the person is awake. Then 10:30, so if you see 10:30 and 10:30, this person reached at S1 stage, and by 10:30, he's reached at S2 stage. And as we are approaching 11 o'clock, this person has reached at S4 stage, which is deep sleep. So if you see where 23 is written, and you see that he spent several minutes, like 4 or 5 or 10, 20, 30 minutes in deep sleep, and then cycle went up, and this person at 11:15, if you see, went again as S2 stage, and then back and forth, and at midnight is the first time when this person entered at REM sleep, and that's what we see, 90 minutes window typically. So now you see the slow wave sleep, which is also called deep sleep or non-wave, is decreasing as we are getting up in the morning, and dreaming sleep is becoming more prominent as we are getting up in the morning. So if someone presents to you with the pathology of REM sleep, and there's a huge one pathology is called, you will see a lot of family doctors probably know this, when elderly people usually kick and becomes very aggressive in sleep, and they hit bed partners, they hit themselves. We call it REM behavioral disorders. So you see, in REM, we need to, by default, normally we have to be paralyzed. But what's happening is the paralysis is not there, and hence it is a pathology, and we need to treat with medication. And when we lose paralysis, then body is not in our control, and hence we are hitting anyone, everyone, and hitting ourselves. When you're asking the questions, if someone says that, hey, I'm hitting my wife or my bed partner early, let's say 11 o'clock, well, that's, this is a behavior. This is not what REM behavioral disorder is. Probably he wants to hit his wife or his bed partner. But if someone is hitting his second phase part of his sleep, we understand that there will be REM predominance, and hence he's losing paralysis in REM. So that's how we dissect sometimes in history and any sleep disorders. So you see, red one here is REM sleep, and as we are getting up in the morning, REM sleep, and we have some physiological changes in REM sleep, both in men and women differently, and hence we wake up with the same thing. We wake up curled up. Why? We don't wake up like this. We don't wake up straight the way we went to bed, the way we initiated our sleep. We usually wake up in a C shape. Why? Because in REM sleep, your body temperature decreases and you are more colder. And I can go on and on and on. There's a list of things, physiological things, that in men, different in women. That happens when you get up in the morning. So that is normal sleep. So nutshell, we have dreaming sleep, non-dreaming sleep, dreaming sleep early in the morning, non-dreaming sleep or early at night before as you go to bed.
Dr. Parmar, before you just move on, there was a question in the chat. It's Dr. Jiwa asks, how much time between normal stages normally? Does it vary per individuals or is there an average?
There is average. It varies with individual. Sleep is all natural way. So when it comes to natural, there's no black and white. Now, answering your question, how much, if we say, hey, ideally, how much time you should spend before you hit REM stage? The answer in your exams will be 90 minutes, but in reality, we see that it's 70 to 100 or 150. And also, since we are talking about medications, all the antidepressants, I'm a psychiatrist, so I can talk about antidepressant medications. All the antidepressant medications, we think that they don't sleep well because of depression and anxiety, but no, all the antidepressant medication knock your REM off. And hence, you need to have good proportion of sleep in like you should have around 25% of REM. It's not that you only have deep sleep, you won't be refreshed in the morning. If I give you a medication like benzos, if I sedate you with opioids, and there's only deep sleep, you won't be feeling refreshed in the morning. Trust me. You have to have good proportion. The way nature has designed for you, that's the way it should be. So sleep is a natural thing. Now, answering your question, 90 minutes approximately REM stage. But if I'm taking Zoloft, I'm taking Cipralex, my REM won't be there in my brain. It will be early in the morning, or it won't be 25%, it will be 5%, 10%. People like me, I will be surprised when I see the sleep study. I said, hey, why the hell the REM is not there in your sleep study? Then I'm going to go back in consult that I did and see there's Zoloft. I said, aha, there's no questions asked. In other way, if someone is depressed, if I'm depressed but unmedicated, I'm significantly clinically neurovegetative, I have neurovegetative symptoms of depression, I will have REM all over. So 25% is going to become 35 or 45. And I will be like, why the hell you have so much high REM in your brain based on I didn't see the patient, let's assume it just based on the history. Then I'm going to go back and ask, hey, we found that your REM is quite high. Are you feeling okay? Blah, blah, blah. So if there is no medication. So there is and I can go on and on about infections, about antibiotics. And again, that's not a scope or the talk today. What answering your question, yes, it should be proportional, and there is a range. It's not black and white.
Thank you.
So moving as we age, now we all know children sleep quite long. You see in this graph, 3 to 4 5 hours is so I mean, as we age, so the sleep hours sleep decreases, deep sleep decreases. That's why people who are older, they get up very early in the morning, and that's another problem. When you see 80-year-old patient and you are looking for a hypnotic medication, you have to really think about whether there is a problem falling asleep or staying asleep or getting up early. REM but total sleep declines rapidly from childhood, rapidly and continuously, gradually decline throughout our life. But REM stays same. Again, I won't go in detail, but that's what if you see a 15-year-old person with initial insomnia, and then there is a problem. Maybe there's a sleep, majority of the time, 99% of the time, there is a sleep hygiene problem in teenagers unless they have anxiety. As compared to 85-year-old person or 80-year-old person, there will be totally different pathology we will be dealing with. And that's the purpose of this slide. The sleep number of hours as we get older decreases, and our capacity to sleep well also decreases. Now, most of us, if we get up at 5 or 6 o'clock, we will be feeling sleepy at 1 o'clock, no matter how strong of a person you have, no matter how high ADHD spectrum you have, no matter what it is, there is a circadian rhythm. So 1 o'clock, 2 o'clock, normal physiology, you will be feeling sedated. Majority of the time we don't realize that because we are walking around and running around based on our lifestyles. But if you have nothing to do, you will see that your alertness goes down a little bit, and that is a normal physiology, and you don't have to make a big deal out of it. Okay. So that's it. So that is, I think I spent and finished in 15 minutes. That was the whole point. So the point here is what is normal sleep, what is REM, what is non-REM, and now we're going to talk about pathology of these problems as well. Again, if there is any question, I can pause for a minute and before we go to next section where we will be spending again 10 minutes.
Nope, no questions so far, unless anybody has one that they want to quickly raise their hand or unmute.
So this is how much time between end stage normally does it vary individual? Oh yeah, this is the answer. Okay, awesome. Okay, so that was normal sleep. Now, how do we measure sleep? Now, so first of all, when you're taking sleep history, when you're evaluating a patient with insomnia, let's say if I'm a patient, I comes to you, hey, can I have a medication, Zopiclone or something? So there are 2-3 questions you need to ask me. First of all, you don't want to sedate me to the point that I stop breathing at night, right? So, and you're going to focus on your questions about nighttime problems, daytime problems. So if nighttime problems is what is your problem at night? And second is because of your problem at night, how is it affecting your daytime? So for instance, if I comes to you, I tell you, hey, I am snore quite a bit. I wake up multiple times. I choke at night. When I get up in the morning, my mouth is dry. Well, don't feel refreshed. I feel foggy. Sometimes I have headaches in the morning. Okay, fair enough. So then what about daytime? Oh, well, daytime I'm tired. Hey, do you fall asleep while driving? Oh, yes, I doze off while falling asleep. Important question, daytime and nighttime. Same as insomnia. If someone don't fall asleep. So it's important for us to divide our history taking into 2 categories. Typically, we are talking about medication and insomnia today, not sleep apnea. But if someone comes to us about insomnia, it's easy to throw the medications. That's the most easiest thing. Difficult thing is for both prescribers and the patient is to follow up the rules. If someone has initial insomnia, a thought should come to our mind. Why this person has initial insomnia? Because sleep is a natural thing and it should not get disturbed. So you're going to ask about what time you go to bed, for instance, 10 o'clock. Okay, and what time you sleep? 11 o'clock. It takes 1 hour for me to sleep. So what do you do for 1 hour is the most important question in doing assessment for insomnia. Okay, so maybe they are on electronics. Maybe they're chatting. Maybe they are doing something that you don't want them to do. For instance, they're reading in bed. That's bad. They're listening music in bed. That's bad. They're doing mindfulness exercises in bed. That's even bad, even worse. They're stimulated in bed. Worse, right? So then they sleep in next day. Then how the hell are they going to sleep the next night? They won't be. So it's important. Sleep onset, nighttime routine, sleep environment, bedtime, sleep latency. What do they do before sleep? Do they do marijuana? Do they drink alcohol? Do they drink coffee? All these things are important. Okay. So majority of the patient probably you're going to see with insomnia has majority of the patient that you're going to see with insomnia has initial insomnia, and they are the patient you're going to be really, really stressed about those patients. But a lot of times people are going to come to you that I don't have any falling sleep problem, but I wake up in the middle of night multiple times. Why would someone wake up in the middle of night multiple times? To go to the washroom? Okay. Do they have undiagnosed diabetes? Okay. Do they stop breathing and that's what they wake up to drink water? What wakes them up? Okay. Do they sleepwalk? Do they sleep talk? Do they grind their teeth a lot? Do they eat in sleep? Do they go out of the house in sleep? All these questions because that's not normal, someone to stay asleep. Yes, initial insomnia, we can say that it's more common. You are stressed, there's so much going on in your bed, and you're thinking, overthinking, or you have anxiety. So, but why would someone has maintenance insomnia is a question that we need to ask, because that's how our differentials are gonna come out. Then waking up in the morning. Okay, what's your morning routine like? A lot of people have what we call sleep inertia. That's a word we use. So when you get up in the morning, majority of the world immediately get up. Okay, I had good night's sleep, let's start. But some people are sleep drunk. What it is, it takes 15 to 20 to 30 minutes to fully come to consciousness. They're just sitting around, laying around as if, I mean, in middle age we don't do it, but in otherwise, if you have nothing to do, you just sit around, lay around. Quite a bit of waste of time. But some people have this every single day. They feel foggy, they don't feel sharp, they have to drink coffee or stimulant, just, I mean, any energy drink, in order to feel sharper. Otherwise they may have headaches. A lot of people get up with headaches in the morning. A lot of people have irregular rising time. So those things are very important, and that's how we measure sleep. And then daytime. How much coffee do they drink? I have seen today, I saw a patient who she drank 5 or 6 pots of coffee, not cups of coffee. So how would you expect Zopiclone going to work for her? Probably not. Why do someone drink that much coffee is the question. Question is not criticizing her. Question is because she had severe sleep apnea and she need to feel sharper. She keep drinking. Initially, the concept was for insomnia. So moral of the story is, sometimes we think that we sleep 8 hours, that our sleep is good. Majority of the patients are gonna laugh at you. Hey, I don't need any problem because moment I hit the bed, I sleep. That is a pathology. If you hit the bed and you don't sleep, that's a pathology as well. Why would someone hit the bed and sleep and brag about it? Because they're sleep deprived all the time. You have to really, really focus on that question as well. Important. If someone is sleep deprived all the time, of course, you're going to sleep wherever and however. And that's what a lot of long distance truck drivers, we see that they say those kind of things. So you need to really be careful what patient is saying to us. So in sleep medicine, this scale called Epworth scale is very important. And this tells us subjective sleepiness during daytime. So when you come from work in the evening, when you're watching TV or something, you're sitting and reading, do you tend to doze off? And you have scale 0, 1, 2, 3, watching television, okay, sitting inactive in public space. As a passenger in the car, laying down and resting in the afternoon if you fall asleep, sitting and talking to someone, sitting quietly after lunch with no alcohol, right? So things like that, or in car while stopped for a few minutes. So this questionnaire is the most important questionnaire for sleep medicine. And we see that whether it's normal sleep apnea, or narcolepsy, or pathological sleepiness, and we go with that. Now, we do maintain sleep diary. I won't go in detail in the interest of time, but sleep diaries are basically, we ask patients, hey, rather than asking us questions and spending 15 minutes, why don't you fill it and I'll just review it? It's more efficient way of getting those answers that I was talking. What time you go to sleep, how much time it took for you to fall asleep, how many hours you sleep, what happened. So sleep diary is a more efficient way of getting that history. And it's important, if someone has insomnia as a complaint, your receptionist or secretary get this Epworth sleepiness scale filled, or a sleep diary filled. It's going to save so much time of you, and you just have to glance for a few seconds and you know what the person has been struggling with. You don't have to ask all sorts of questions. And also monitor. If you're really doing cognitive behavioral therapy for insomnia, you can monitor whether they're feeling better or not. Now, next one is polysomnography. Now, this is the most important test. Little bit history, I will spend 1 minute on this. Polysomnography is called overnight polysomnography. So you go to a sleep lab. We have 3 sleep labs. One is in Surrey, which is in front of Surrey Memorial Hospital. It's called Surrey Sleep Clinic. One is in BC Children's Hospital. It's called UBC Sleep Clinic. One is in Abbotsford. It's called Abbotsford Regional Hospital Sleep Clinic. There was one in Richmond, which is closing next week. So technically, we have only 3 here in our area. And then we have, I think, Chilliwack or Kelowna one. And then we have one in Nanaimo. So these 3 sleep clinics there is no waiting time much. UBC Sleep Clinic has a little bit waiting time, but other sleep clinics have not much waiting time. I think it's important you use these services. Overnight polysomnography is you go to sleep clinic, you sleep over. So what we do is we put EEGs like this. You put EEG, we measure for sleep staging, we put wires here, we could put here, we put leads all over you, and then we let you sleep all night, and we connect you with the computer, and then we measure everything, that the way I'm saying, REM sleep, deep sleep, snoring, this, not snoring, of course, but whether you stop breathing or not, whether you have apnea, whether you have hypoapnea, whether you have RLS, whether you have RLS means restless leg syndrome, whether you have REM behavior, whether you sleepwalk, whether you sleep eat, whether you have any sort of parasomnias. So that is what we call sleep study. It's also called overnight polysomnography study, which is a gold standard diagnostic test, and it tells us every single thing. Okay. So there's another thing. I won't go in MSLT in interest of time, and because I want to spend next 20 minutes on this, because that's what we're meeting here. But there is something called MSLT also, which is called multiple sleep latency test. If I'm coming to you, hey, my problem is not insomnia, my problem is sleeping too much. Okay, why the hell you sleep too much? You have either what we call idiopathic hypersomnolence, means you sleep too much, or you are sleep deprived at night, or you have sleep apnea, or you have narcolepsy. Okay, sleep apnea is easy to measure. Tonight you come to sleep lab, we do the sleep study, and we black and white we find out whether you have sleep apnea or not. It's important, if you're a physician, to refer to a physician for sleep apnea or any sort of assessment like that, who has no financial interest in selling the medications or in selling the products that is used for the treatment for sleep apnea. So as for medical legally, for CPS BC guidelines, if you say it's important for you as a physician, you make a referral to a physician. Now, MSRT is after overnight sleep, overnight polysomnography study. Next day, we make them sit for 3 to 4 hours. We give them choices to sleep. And if they, even after a good night's sleep, if they end up falling asleep, then we diagnose them with idiopathic hypersomnolence. Or if they get REM sleep, this is narcolepsy, which is another illness, which I won't go in detail today. So that's how we measure sleep. So summarizing this, I think I'm going way too faster, but summarizing this, to measure insomnia, it's important to do a sleep diary. It's important to ask all sorts of questions in the history for sleep onset, maintenance insomnia, terminal insomnia, and daytime symptoms, and be aware that there are facilities available for overnight polysomnography studies in our area. Again, before we go further, we'll stop here if you have any questions. Okay, so if you have no question, then we're gonna talk about sleep and mental illness, and that's what we're going to spend a little bit time, rest of the presentation for 15-20 minutes. So I think someone
Dr.
raised.
Jiva has raised her hand, Dr. Parmar. Go ahead, Dr. Jiva.
Hi, Dr. Parmar. I'm just wondering, when you do the polysomnography, how do you account for a different environment? So when a person is comfortable sleeping in their own home, but they come to your lab and they have a different environment, would that not affect the onset of sleep for them or the time they spend in REM sleep? Because I know myself, when I travel, I'm very uncomfortable for a few nights in a different environment.
Fair enough. This polysomnography study measures quality of sleep, not quantity of sleep. So when if I go to bed, and in my house it takes me 15 minutes to fall asleep, but I'm not comfortable in any, no matter how better the environment is, somewhere outside it may take you 2 hours, 1 hour to fall asleep, but then you're going to fall asleep. We're going to give you 9 or 10 hours to fall asleep. To get to the accurate data, we just need 4 hours of your sleep. So in those 4 hours, again, we are going to assess whether there is any quality pathology in sleep, whether you stop breathing at night, whether you are having many movement disorder, restless, like all those things, right? Whatever comes in the chapter of sleep disorders, whether you have those problems. Not insomnia. Insomnia only when you wake up in the middle of night. So we factor those things in the results. For example, if someone stopped breathing, if someone has severe sleep apnea based on the study, but we noted that he slept only 4 hours. Typically people sleep 7 or 8 hours. We're going to say that, hey, the numbers would be a little bit inflated, but you have so much apneas. Yes, you have severe sleep apnea, number could be inflated, but seems like this is something that would help you treatment of this sleep apnea. If you want to repeat the study, we can do that. We can use the medications also, because the purpose is to not measure the quantity, is to measure the quality. And for that, you just need to sleep. Good.
Thank you.
Okay, so what does mental health issues or mental illnesses do to our sleep? Depression. You won't see any. If you see 10 people with significant clinical depression, they will either sleep too much or they don't sleep at all. Two spectrum. If they don't sleep at all, this person probably has anxiety also. So we call it major depressive disorder with anxious distress. Or in general, they have anxiety on top of their depression as well. Or they have premorbid anxiety, and on top you got depressed. So depression and poor quality of sleep go hand in hand. Depression worsens sleep efficiency. Sleep efficiency. Now, this is very important. Of course, if sleep efficiency is number of hours you spend in bed divided by number of hours sleeping. So numbers of hours sleeping, number of hours in bed. If I sleep 5 hours, but I spend 10 hours in bed, sleep efficiency is 50%. We want sleep efficiency to 90%. And how do we do that? Either I make this 10 out of 10 and make it 100%. How can I do that? I sedate you with alcohol, I sedate you with opiates, I sedate you with zopiclone, I sedate you with Seroquel, and hence it's 10 out of 10, and I'm happy your sleep efficiency is 100%. Or I don't do that. This is the best approach. I reduced 10 hours in bed to 5 hours in bed, and hence it becomes 5 divided by 5 and 100% efficiency. And that is the most important point when you're explaining sleep hygiene, because sleep hygiene means when people have depression, they lay around all day. When they have anxiety, they lay around all day. The brain in bed, the brain get conditioned that bed is not for sleeping. It's for everything else than sleeping. Since childhood, our brain is conditioned to bed, just like Pavlov's experiment. You see chocolate, your mouth start watering, because since childhood that this chocolate is something that's my favorite and tastes good. So though the chocolate is not in your mouth start watering, which is Pavlov's experiment. Since childhood, we have seen, hey, bed, moment you go to bed, your brain say, hey, time to fall asleep. That's called conditioning. When we have depression, when we have anxiety, when we have all sorts of problems or stress in our life, we go to bed and we start overthinking. Okay, not a problem. You didn't sleep well last night. but you do start doing every single day. What happens then? The brain get deconditioned. It's like me giving you same favorite moldy chocolate and you spit it out, moldy chocolate, spit it out after 10 times, your mouth is going to stop watering, which is deconditioning now. So that's how we decondition ourselves, and hence we develop what we call chronic insomnia. And people in your clinic will say, hey, I was never a good sleeper, and now it has gotten worse after XYZ things. And this is probably normally you see in your clinics as well. Reason, they have not conditioned they have not worked hard to recondition their brain with bed and sleep. And that's what I was telling before, is some people do mindfulness in bed thinking that they're going to sleep, but they don't know even that is a negative thing. Doing mindfulness in bed or doing something in bed, you're associating XYZ things with sleep. That's not a good idea. Do it outside the bed and then come back to your bed, because the moment your brain sees bed, it should fall asleep. Depression make your sleep efficiency worse, sleep continuity worse, and it decreases slow wave. It decreases deep sleep. So as a result, you won't get refreshing sleep. But depression also increases REM sleep. Remember, we talked about REM sleep. Depression goes high. So you're dreaming too much. And they're going to say, I am having vivid dreams. And you don't know whether the vivid dreams is Cipralex that you started is causing it, or it's caused by depression. They're going to say, I have graphic dreams, and all those words that you probably hear on a daily basis. So that's what depression causes. Antidepressants, opposite. Antidepressant take your REM away. You don't have REM. Both the things are bad. We need proper concentration, or whatever, proper proportion of all the sleep stages. So not only depression is bad for sleep, antidepressant is bad for sleep as well. There was in 70s or 80s, even after World War, one was the most potent antidepressant. It was sleep deprivation. So if you deprive someone from sleep, they feel happy, though it's not sustainable. So if I don't let you sleep today and tomorrow you will be exhausted, but it will be there is a euphoric feeling is going to come. And hence we say that sleep deprivation also is a potent antidepressant. But if someone has bipolar disorder, you can become manic, super happy after sleep deprivation. Schizophrenia, also similar. It shortens your REM latency. It's too much REM, just like depression. It's a similar poor quality of sleep, decrease in slow wave. What does alcohol do? Why does alcohol help you sleep immediately, short term? Because it's sedating in short term, because it acts on same receptors that benzos act, but long term it suppresses your REM sleep, so you won't be dreaming, and it wakes you up. If you're like intoxicated tonight, tomorrow you're going to get up very early around 3 o'clock. Why? Because that alcohol sedation effect has gone out, half-life is done, and now you're up at 4 o'clock again, and you're not able to fall asleep, and you're hungover, things like that. So the moral of the story here is mental illnesses, depression, psychosis, anxiety, they lead to poor quality of sleep. Anxiety leads to initial insomnia, but antidepressant that we use them to treat also leads to poor quality of sleep. Now, what the hell we do? What should we do then? How should we fix sleep? Now, out of all the antidepressant medication, I think most of us if you are using antidepressants, if you're using hypnotic medication, use antidepressants or antipsychotics for hypnosis. And that's the purpose why we are doing this presentation as well. I think shy away from Z drugs. I don't know, you must have some patients in your clinic, they're taking Zopiclone for 20 years and still they're taking it. Well, sleep is a natural thing. There's a reason why they're still taking it, right? You won't see someone taking Seroquel for 20 years, for instance, right? You won't see other medications. You will see only Zopiclone or benzodiazepines, mostly Zopiclones. So shy away from Z drugs because they're addicted to Z drugs. The medications that we can use for initial or maintenance insomnia could be mirtazapine, Remeron, which is an antidepressant medication, and it helps in improving slow wave sleep, and it helps in improving REM sleep. The problem with with mirtazapine is it can lead to weight gain, or people can be groggy in the morning. So if they're groggy, reduce the dose or tell them to take it a little bit earlier in the evening. Let's say that means the reason why they're groggy is because medication still is in their system. So tell them to take them early. So that could be an option, good option, mirtazapine. Wellbutrin is the only antidepressant that is good for sleep, in the sense it's not negative on sleep. It's not positive, it's not negative. It spares destruction of sleep architecture like other SSRIs. Now, benzodiazepines, zolpidem. Zolpidem is the world's most prescribed hypnotic medication. In Canada, zolpidem is prescribed as Sublinox. It's marketed as Sublinox. In the world, it is Ambien. So this is the world's most prescribed hypnotic medication, zolpidem. In Canada, we don't use that much. It's because of the marketing. It's similar to zopiclone. Zopiclone is not available anywhere else, not even in US. It's only in Canada. So zopiclone we use good, but they help in initial insomnia. That's why they immediately act on it. But then over the years, people get tolerant to it, and then you have to increase dose further and further. So that could be an option if you really someone who wants to use it for PRN basis. Quetiapine, Seroquel. Seroquel is another option, which is a good sleep architecture sparing medication. At low doses, it only acts on H1 receptors, so it's technically Benadryl. So 12.5 milligram, 25 milligram, 75 milligram, 50 milligram, or even 100 milligram. It acts only on H1 receptor and could be a good medication for initial and maintenance insomnia. And if you go beyond 300 milligram, 400 milligram, it becomes antipsychotics after that. So that was the basically what happens in mental illness and medications. Now, this is briefly another 5 minutes I'm going to spend, and then before we go to the last part, which is another 5 minutes. So when we talk about DSM, our psychiatric DSM sleep wake disorder chapter, you have insomnia disorder. Of course, you have initial insomnia, maintenance insomnia, terminal insomnia. That's that problem. You have hypersomnia, which is you're sleeping too much. Either you're narcolepsy or we don't know why you sleep too much. Or breathing related sleep disorder like obstructive sleep apnea. And that means something is obstructing here. As a result, air is not going to the lungs, and hence it's not going to the brain. And brain is oxygen deprived at night, and brain wakes you up repeatedly. Hey, I'm not getting enough enough oxygen, and hence it's waking you up frequently. Or you gasp for breath, or your mouth is dry. All right. So then in the morning you feel groggy and unrefreshed as well. Then we have other issues. Then we have circadian rhythm, which we see all the time for children. Circadian rhythm is, of course, you delayed sleep phase type and all type. And then we have REM behavioral disorder. Then we have nightmare disorder, restless leg syndrome. This is all sleep problems. Good. So,
Dr. Parmar, there was a question in the chat. It says, how about trazodone?
Yes. Trazodone, I'm going to come to in the end, but trazodone is another antidepressant medication. So if we talk about antidepressant medication that we can use, I think for sleep, if someone can write, that would be helpful. Remeron, mirtazapine, doxapine, TCA, which is marketed in Canada as Silenor, Silenor, trazodone. Now, trazodone is not going to help you with maintenance, with initial insomnia at all. And that's why I don't know if you prescribe 10 people trazodone, how many of them are happy about it? It helps people with maintenance insomnia because of the half-life. And hence, majority of the time, patients are going to come to you and you're going to say that, hey, I feel groggy in the morning. I didn't feel good. I don't want to take it. And then you're stuck with the medications. Trazodone could be helpful if someone has maintenance insomnia. And majority of the time, people who come to you and ask for medications, they have initial insomnia. So that's one of the reason why trazodone, though you prescribe a lot and we all prescribe a lot and we think this is the safest option, it may not work. Yes, if someone is frequently waking up in the middle of night, it's good. You can give them early, like let's say your bedtime is around 11 o'clock, you can give it 9 o'clock, and then you have things like that. You can even supplement with melatonin and trazodone and do that as well. You can start with 25, 50. The problem with trazodone is after 100 milligram, it's not sedating at all. So if you want really a sedation, you have to have 25, 50, 75 and give it up after that. It's not going to work after 100 milligram.
I'm not sure if you're getting to medications a little bit later in the presentation. There's one more question here, so you may get to it a little later. But what dose of Remeron, Wellbutrin, or quetiapine do you recommend for sleep? And I don't know if I pronounced the last one correctly, but I'm sure you know what I mean.
I'm so sorry I'm going so fast because there's so much to cover. Wellbutrin is not for sleep. The purpose for that slide was are all antidepressants bad for sleep? Then which one is the better for sleep? Wellbutrin is the one who spares sleep architecture, but it's not a sleeping medication. It doesn't help people sleep. In matter of fact, wakes you up. Wellbutrin is increase of dopamine. You're going to feel energetic on it. So the reason why I mentioned that is it does not affect your sleep at all, negatively or positively. Mirtazapine, Remeron, we start with 7.5 milligram. Matter of fact, you should use this as a first-line choice for elderly people as an option. 7.5 milligram, we go 15 milligram, we go 30 milligram. If you want to use this as antidepressant medication, you can go up to 45 milligram. But if you want to use it as a sleeping medication, there's no need to go beyond 30 milligrams because it won't be sedating or it won't have any additional benefit. Matter of fact, weight gain is dose dependent as well. So answering your question, I would give 7.5 milligram and tell the patients take 1 or 2 tablets, or give 15 milligrams, say you can cut it into half if you're extremely groggy next day. So that is the answer. Good?
Yep, okay. Thank you so much.
And quetiapine also was another one. Quetiapine, we'll start with 25 milligram, and of course, you can go up to 100 or even more. What you can say that, hey, this is a 25 milligram tablet, start with that. If it's too much, cut it into half or take 2. So play with the medication from 12.5 to 50 or even 75, whatever the medication works for you. And matter of fact, quetiapine, if you see, 45% of share, like if you see market share of all the psychiatry medication, 45% is quetiapine. Rest, no matter what medication you see, whether it's antipsychotic, antidepressant, all these are 55% together. So the reason why quetiapine is prescribed so much is not because it's a medication for schizophrenia, not because of hypnotic medication. It's the most commonly prescribed medication. And I think guys should use it too. The problem is weight gain, but it's dose dependent as well. And if someone is happy with 25 milligram or 50, you don't have to have 300 milligram, 400 milligram, which can lead to weight gain as well. So it's a dose dependent. Okay. Okay, so I think I went very fast here.
We still have another 30 minutes, so don't feel like you have
okay.
Yeah,
I thought we were finishing at 7 o'clock.
No, it's 7:30. You're good to go still.
Okay, so then I can take my time.
Yes.
So yes, so this one. So I think if I'm a family doctor, my main nightmare is to treat insomnia, and I don't want to use Zopiclone. And that's the question majority of us should get answered today. That is, second thing is there is an odd patient you will see who comes with restless leg syndrome. And what investigations do I do before I say that this is restless leg syndrome? And also, what are the different things? Though I know what CBT insomnia is, what are things? Why do CBT insomnia, which is cognitive behavioral therapy for insomnia, works if someone is willing to do it? So anyways, so we have in sleep disorder clinic, we see sleepwalking, sleep talking, sleep eating, aggressive in sleep, people having fights with police officers, on the road, driving in sleep. So those are parasomnias. We see people, this is a real example, speaking in different language, which they have never learned in sleep. We see people who does criminal activities in sleep, for instance, raping in sleep. Sexual disorders also, we see people having sexomania in sleep, which means sexomania is when you have you just do different things which you would not do in terms of sexual preferences while sleeping. We see a lot of people sleep eating disorder is so common to the point that they gain so much weight and they don't know when they're eating. Those are some of the sleep disorder problems. Sleep apnea is another one, which is the most common sleep disorder. So what is sleep apnea? So sleep apnea is, if you see this, the air goes there and then you get stuck here when you sleep, especially on your back. So a soft palate closes and closes. How do we treat it? We treat with the CPAP device. CPAP device is called continuous positive airway pressure. So you see continuously it creates a space there, and that's how you feel better. And then air goes in, and you get so refreshing sleep, and it adds some years to your life because less chances of heart attack and stroke if your sleep apnea is managed. Restless legs, I just skipped narcolepsy because it's rare, and if someone has narcolepsy, probably you will be referring to sleep disorder clinic. The restless leg syndrome is the most common thing, which I think should be managed by family doctors. Someone comes with restless leg syndrome, they get this antsy feeling. They get the feeling that you need to move your legs in order to feel better. So you get this uncomfortable feeling in your legs that you need to move your legs and to feel better. As a result, you walk. If you don't, you don't feel relaxed. Before you go to bed, it starts affecting your sleep because it prevents you falling asleep. So you get these aches and pains and this, that, and typically it gets worse in the evening and occurs at rest and relieved with the moment. These are the three things. And at night, in the middle of night, because now they're resting, they move a lot. And restlessness or restless leg syndrome that happens in sleep, we call it periodic leg movement disorder, and that very clearly we can figure out from in overnight polysomnography study. The most common cause for restless leg syndrome is idiopathic, but second most common cause is low ferritin level. If someone is losing blood through menses, or if someone is pregnant, or someone has chronic renal failure, those are the other causes of restless leg syndrome. And by default, treating restless leg syndrome is finding out why someone is having restless leg syndrome and then diagnosing them whether it's idiopathic or not. If someone's ferritin level is 10, 15, 20, we know this could be a reason why they're having restless leg syndrome. So maybe iron supplements, which probably won't work. Maybe intravenous iron would help. Whatever, if the iron goes up, the restless legs gonna get better. Pregnancy is the most common, also quite common in our world. Pregnancy and restless leg syndrome. Moment that they're not pregnant, then the restless leg syndrome get better. End-stage renal failure is another issue that we see all the time. Antidepressant medication also can cause restless leg syndrome. Antipsychotic medication can cause akathisia. So all these things cause restless leg syndrome. But let's assume you diagnose restless leg syndrome as idiopathic. The treatment is pramipexole, Miropax, which is very common, the most first-line choice, or Lyrica, pregabalin, gabapentin, ropenolol, which is kind of not that much available, and benzodiazepine. People like me, when they're so severe, we treat them with opioids as well, but those are very extreme rare cases. I mean, 1 out of 20 patients that we see. But majority of the patients get better with pramipexole, gabapentin, pregabalin, one of these three or benzodiazepine, one of these 4 medications. A lot of times we combine pramipexole and Lyrica and then clonazepam so that we don't have to go to to opioids. So these are extreme cases where you have idiopathic hypersomnolence. Okay, so insomnia is what we're going to spend next few minutes. I don't have to go in detail how common insomnia is. If I ask you in your clinics, probably you will see 2 or 3 patients per week with insomnia, either you to renew the medications or they want the medication for insomnia. In our world, it's the most common, and majority of the time we see that they have underlying mental illnesses as well. If someone is insomnia, majority of the time we see depression or anxiety, mostly anxiety. Among adult patients, 40% of people report more than one symptom of insomnia for 3 weeks, 3 times a week. So they're not satisfied. Majority of 20% of people are not satisfied with this sleep, right? So majority of the time they have difficulty in falling asleep, or they wake up multiple times, or they wake up very early in the morning, or once they wake up in the middle of night, it's difficult for to fall back to sleep. And all these things leads them to have not refreshing sleep in the morning. So anxiety, mood disorders, substance disorder, and also if there is secondary issues like, for example, pain, if they have orthopnea, if they have a congestive heart failure, or if they have obesity, they have obesity hypoventilation syndrome, things like that. So when we are talking about insomnia, we talk about medical factors like pain, nocturia. A lot of times we see people having frequent micturition at night, which could be a symptom of obstructive sleep apnea. But we see they may have overactive bladder. They may have diabetes, which has not been diagnosed. So all these things need to be evaluated as well. So then there are psychological factors like depression, anxiety, stress. Then we have chemical factors like caffeine, alcohol, if they're drinking too much alcohol every single night, or they drink too much coffee, right? And even medications, if they are on that, leads them. Then, of course, environmental factor like noise, temperature, or there is other factors like, for example, if they have post-traumatic stress disorder, they may have nightmares, they may have restless leg syndrome, they may have sleep apnea that's causing insomnia to them. And if all these factors are eliminated, that's what we call primary insomnia. So when we see patients with insomnia, that's what our history of presenting illness is like. To rule out, if someone is in a chief complaint is insomnia, to rule out all these things, we talk about depression, anxiety, we rule out sleep apnea, we rule out nightmares, we rule out parasomnias, we rule out all these things before we stamp it as insomnia disorder. How do you treat insomnia is important without medication. With medication, it's easy, but without medication is something needs discipline from the therapist and for the patient also, mostly patient. The main point is what we talked about, sleep efficiency. So 5 hours sleeping divided by 10 hours in bed, so 50% sleep efficiency. Either I give you medication to make it 10 out of 10, or I reduce the time in bed and deprive you from sleep to make it 5 out of 5, to make it 100% sleep efficient. And that's the bottom. That's called sleep restriction therapy. And that is what we need to learn today. So first thing first, when I'm the patient and you guys are, and your doctor, and you're going to ask me in my history if I'm practicing good sleep hygiene techniques or not. That means I have a regular sleeping and rising time. I don't stay in bed if I'm not sleeping. I use only bed for sleeping. I don't take a nap during daytime, things like that. Once those things are okay, those things first. So first, if there's any problem, tell the patients that this is what you need to do. If that does not get better, then we go to what we call stimulus control therapy or sleep restriction therapy. And sleep restriction therapy it's other way around. It's not that I'm giving you medication, Zopiclone, to help you sleep. I'm going to deprive you from sleep so that you sleep well. And how I'm going to do it? So let's see. So the goal is the brain has no problem, which you identified already in history of presenting illness. You identified I don't have sleep apnea. You identified I don't have depression. You identified all that I'm practicing good sleep hygiene techniques. Now, you know that my brain by default is going to fall asleep at night, provided I regulate your cycle. So if you deprive me from sleep, my chances of falling asleep next night will be better. So my chief complaint to you, doctor, is I go to bed at 10 o'clock, I stay in bed for 2-3 hours, and I end up falling asleep around 1 o'clock, and then I get up at 6 o'clock. Sometimes I sleep in, and I don't feel refreshed, and I want medication that can immediately make me fall asleep at 6 o'clock. And this I have been doing for 20 years. That's the patient, typical patient, you would see that. This is what I'm going to do. Okay, simple question. What time do you want to wake up in the morning, 7 days a week, consistently based on your lifestyle? Okay, 5 o'clock or 6, let's assume for discussion purposes, 6 o'clock. Okay, now religiously get up at 6 o'clock in the morning, no matter how you sleep at night. Okay, well, that's not going to happen, blah, 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 but you have to do it. So 6 o'clock, you get up, set the alarm at 6 o'clock, get up, and 6 o'clock, no sleep drunkenness. 6 o'clock up means you're up, out of the bed, day has started, do your morning routine, do whatever. Throughout the day, don't take nap, do exercise in the morning, not late at night, do whatever. And your sleeping time is at 11:30, which is 6.5 hours or 7 hours. Let's say for discussion purposes, we say 7 hours. 11 o'clock is your sleeping time. But that's not enough time, because I usually sleep 8 hours. That's okay. We are going to restrict your brain. We're not going to let you sleep. So tonight, 11 o'clock you should go to bed. 11 o'clock go to bed. You will be tossing and turning. Not you get up. You don't stay in bed. Get up. Do mindfulness outside the bedroom. Read outside in dim light. And let's say 1 o'clock you want to fall asleep. You are feeling sleepy. You come back. You may not be sleeping again all night. All night, back and forth, back and forth. Let's say finally you end up falling asleep at 4 o'clock in the morning. Now, no matter when you sleep, when you fall asleep, no matter what happens to your night, get up at 6 o'clock in the morning. Now, last night you slept only 2 hours, your next day is ruined, but that's exactly what we want. We want you to be so sleep deprived that you pass out next 11 o'clock. Now, till 11 o'clock, you stand and watch TV, do whatever, but you're not allowed to fall asleep. In that way, so we sometimes give time off work if people are motivated to do that, so that they don't make mistakes, they don't drive and fall asleep during daytime. Majority of the time, that's what I do. So you give the time off if they're motivated. If they're not, then probably you don't have to. So you will be surprised after 4 or 5 nights of struggle, they will be immediately falling asleep at 11 o'clock and getting at 7 o'clock. And after 2 or 3 weeks, when you may do the follow-up after a month, they're going to say, I sleep through the window, but it's not enough sleep. And that's when you add half an hour in the morning or at night. And that's called sleep restriction therapy. And that's how you improve the sleep efficiency without medication. So rules are: limit time in bed, keep a regular sleep hygiene, especially wake up, use the alarm all the time, remove clock from the bedroom. You're not allowed to sleep. So you're not allowed to know the time of the night once you set up the alarm, because that's going to make you anxious that you're not sleeping. How you're going to function next day? You're not allowed to know the time of the night after you set the alarm up. Eat light breakfast, a bedtime snack, reduce the fluid intake in the evening. Don't try to fall asleep or take worries to your bed, things like that. So why do we get this insomnia? Is when we go to bed, we are conditioned with the brain and sleeping, but sometimes our worries and stress activates our area called reticular activating system, and that reticular activating system keeps us active, and that's when our brain gets used to it. So only 5 things in stimulus control therapy: go to bed when you're sleepy. Don't go to bed 11 o'clock every single day, like the way I just said it. If you're not sleeping, get up. Go to bed only when you're sleepy. If you're not sleepy till 3 o'clock in the morning, that's okay. Go to bed at 3 o'clock. But the most important thing is, no matter when you sleep at night, you have to get up at one time that we have decided, which is 6 o'clock. Use the bedroom only for sleeping. Get out of the bedroom when you're unable to sleep. Rise same time every morning, and do not take a nap during daytime. So this is sleep restriction that I was talking about. Now, medications. Medications are important as well. Of course, you can use it on PRN basis, but make sure you know that medications are only and only, it's not needed in sleep. There has to be something else going on, because sleep is a natural phenomenon. You can't be born with insomnia. You can't be. So what medications? Antidepressant, you see the name trazodone there. You see the name mirtazapine there. You see the name doxepin there. Now, doxepin is Tylenol. Tylenol, when we use doxepin, which is TCA, as antidepressant, it is at the dose of 100 and 200 milligram, but we are talking about 3 milligram and 6 milligram. So Tylenol is available in Canada. Doxepin is available in Canada, 3 milligram, 6 milligram. Amitriptyline is also a good option, 5 milligram, 10 milligram, up to 20 milligram. No need to go up to 50. So these are antidepressant medication that you can. Antipsychotic medication, most commonly Seroquel. People like me use risperidone at low doses for children and elderly people as well, mostly children. Olanzapine, I won't use it, but it's also I use typically as well. But the only problem is weight gain, but it's very sedating. It's pretty good medication. For insomnia, all these are recommended medications, or approved medication for insomnia as well. And then we have antidepressant like Nosenan, which is our last resort, which is very strong medication, and we give that. I personally give them a lot. Loxapine, which is typical antipsychotic like loxapine, Nosenan. Atypical like Seroquel, risperidone, olanzapine. And then we have gabapentin. I just wrote it, but it's not that effective for insomnia per se. Then we have Z drugs, zopiclone, zolpidem. Zolpidem is Sublinox. Zopiclone is Imovane. There are other benzos, but none of us in the audience would be interested in prescribing benzos for sleep, so I won't go in detail. But if you answer the question in exams, temazepam is the medication with perfect half-life for sleep. If you have to give one benzo, you decided for insomnia, it should be temazepam. Not benzo Ativan, because Ativan is going to go out of your system in 3 hours and then you wake up as well. Clonazepam, it may not help you with initial insomnia. Temazepam has a perfect half-life for insomnia. So these are some of the options. Now there are some options, new new hypnotic medications in the market, and one of them is, probably you guys have samples in your clinic. It's called Davigo. So Lumbraxant. So those medications like 5 milligram, 10 milligram can be used on PRN basis to help sleep. So I think stick to antidepressant, antipsychotics, and if not, then once in a while for Z drug. But if someone has chronic anxiety, depression, I think it's a good idea to stick to antidepressant, antipsychotic medications. Benadryl is another medication. Melatonin for elderly as well as for children. For sedation could be an option as well. So these are some of the medications. Okay, thank you.
Thank you so much. I think there's one more question here in the chat too. Can you comment on melatonin?
Yes, of course. Now, it's important, where do you buy melatonin, this medication as well? Jameson, Costco has better concentration, the one you buy from them, but there are a lot of product there. They may say that it's 3 milligram or 5 milligram, but the content is not there that much. So I think Costco one is pretty good, and Jameson brand is what they have is pretty good. Now, 3 milligram, 5 milligram, up to 10 milligram. And this medication can be used for two reasons, two purposes. One is for sedation. Sedation means if I take 3 milligram, 5 milligram, 10 milligram right now, within half an hour, I will be sedated. I should be sleeping. Or it can be used to help with delayed sleep phase syndrome. For example, I don't fall asleep till 2 o'clock, 3 o'clock, or 5 o'clock, and you want to switch my cycle to this side. Then it's not for sedation. Then you give me 1 milligram, half milligram, or 1 milligram 5 hours before I go to bed. And this will help me to stimulate melatonin that is produced in my brain. Now, this is a hormone that with the production of this hormone, you sleep. And this is produced whenever sun goes down. So when it's dark, it's produced and we sleep. Now, when we do traveling, that's for jet lag. This is the best medication. Let's say you're going to Europe. It is sleep, but there again, sun is there. So it won't be produced in your brain. So when you take it from outside, it's going to help you sleep for sedation. In your clinic, I think for jet lag, that should be used. For children, try that. And for elderly people, try that as well.
Thank you, Dr. Parmar. Are there other questions that anyone wants to ask? Dr. Jiva, go ahead.
What about insomnia and pregnancy? What drugs would you recommend?
So none, of course. But if you really have to give them, then we go with category C. Category C is the medication that can, trazodone could be an option, right? I have to see mirtazapine, whether those are category C medications. So those are some of the options we have. Seroquel, I would go with Seroquel as well, because Seroquel is category C as well. If I have to choose one medication today, I would go with Seroquel.
Is melatonin safe in pregnancy?
I'm not aware of reading anything wrong with it. I'm not sure about that. I don't have that answer. But again, I'm not aware of it if there is any problem with that.
Thank you.
There are other questions from the group this evening? No. All right. I have put the evaluation link into the chat box for any of you who want to start filling out the evaluation. And in the meantime, just want to say thank you, Dr. Parmar, for spending this evening with us. We certainly appreciate you sharing your knowledge with us and giving us some good information this evening. So thank you so much for your time.
No worries. And if there's any problem, just email me or if there's any other questions related to sleep resources around here. So
will do. And are you comfortable? I know you sent me your slide deck before. Are you comfortable with me sharing out the slides with everyone also? Great. That's wonderful. Thank you so much. So the evaluation form is in the chat box, everyone. So please go ahead and you can fill it out. And as soon as you're finished, please feel free to drop off. Thank you all so much for attending this evening. We appreciate your participation and sticking around with us tonight. Once you're done, have a great night, everyone, and enjoy the rest of your evening. Thank you so much.
thank you. Thank you.